Welcome to We're on ECMO, a video series for the ECMO community where I ask an ECMO question to an ECMO expert and get a 2 to 3 minute response. Today's guest joining us again is Shanna Seigel,
Hi.
Veteran ECMO specialist and part of the ECMO Advantage training team here. Thanks again for joining us. We had a great discussion last time. Looking forward to today. Today's question is, how do you trial a patient off of ECMO?
That's a good question. And just like last time, I'm going to start with it depends.
Okay.
So, today the majority of our patients that we're taking care of are adults and they're on VV ECMO. And so today what I'd like to talk about is something different. I'd like to talk about trialing a small patient off of VA ECMO. So our trial conversation today will be complicated by the fact that the patient is less than 3 kilos. So it's going to be called a clamp trial, where we're actually isolating the patient from the circuit, and we're going to be on a roller pump, and we're going to have a couple of shunts open in our system. So the bridge is already open, and we have a post-aux through the hemofilter to pre-aux shunt. And so the system setup is more challenging than just trialing a VV patient off. So with that in mind, we'll move forward. And so at rounds, you'll talk about your plan, and everybody decides, yep, today looks good, the patient looks good, and we're going to do a trial off. And so for me, in my practice, it's this type of patient is a pretty rare occurrence. I used to do these types of patients when I first started, but just ECMO in general has sort of fallen off the cliff for small patients and just really skyrocketed for adult patients. And so in essence, this patient is going to start at a stable flow, full flow of 100 mils per kilo per minute. And over a period of time, a couple of hours, we're going to walk that down to about 50 mils per kilo per minute. And then I'll sort of expand upon that a little bit later here. But once you've gotten to your point where you think it's time to start your trial off, then you would notify the healthcare team. So what does that look like? Who is going to come to your bedside? So as a minimum, I would think you would need, or I would want, a provider to care for the patient and manage that side. The bedside nurse, the bedside RT, of course myself or you, the bedside ECMO specialist, maybe an extra nurse as a recorder of what's happening, because it's a busy time and it's hard to do all the things and write it down at the same time. And then also we want to ensure that we have notified the surgeon, because if it's a successful trial off and we decide we want to decannulate, we want to make sure that person and their team is available. So we want them to know that that's what our plan is today. So some of the things that we'll talk about once the healthcare team is there is how they'd like to manage the anticoagulation. Some centers split their heparin drip or whatever anticoagulation they're using. Some centers move it all to the patient side, and so just make a plan for that. Make a plan for what ventilator changes you're going to make once you've clamped off, where your escalation starting point is, and also at what point would you not escalate any higher. So what's your stopping point? Make sure we have any emergency drugs drawn up that we think we might need. Hopefully you won't need a code cart, but we'll have that pulled over to the bedside just in case. And then you'll need your point of care blood gas machine. Where I work, that's my job, so that complicates this busy trial off for me. And then we'll have a discussion about our plan, like what is the length that we're looking at? Are we thinking about 20 minutes, 30 minutes, an hour? And we'll talk about the risks. So the longer you trial off with a clamp trial, the riskier it becomes due to the pressure changes that occur as you clamp off and open the clamps to flash the cannulas, and the changes in flow and pressure that occur during that. So that can be risky. And we'll want to talk about what the condition of the circuit looks like prior to doing all that. If it's an old clotty circuit, of course, that risk is higher. If it's a newer circuit, lower. So clamp trials can be kind of busy. So you'll be coordinating then clamping, possibly opening the bridge. In my case, the bridge is already open. You'll turn your sweep off immediately. You'll turn your scuff or CRT off immediately, and then you'll start your timer. The timing on that is different depending on where you work. Some centers will flash the cannulas every 5 minutes. Some will go as long as 10 minutes. So whatever your center is, set your timer slightly less than that period of time. And then when that timer goes off, you will coordinate with the bedside nurse to draw your blood gas, and you will start running that, and then you'll be ready to flash your cannulas and then come back off. So it's this same wash, rinse, repeat every 5 to 10 minutes through the whole length of the trial. And then at some point you have to figure out when you're going to chart all of that. So I like to make a notes page that looks something like this, where I might make note during my decreasing flow what my RPMs are, what my patient flow, my oxygenator flow, and my bridge flow is at various RPMs. And then I also like to make note of the time I started my clamp trial, put some check boxes to make sure I remember to take my sweep, my hemofiltration, and set my timer, and then make timing for when I'm going to draw gas and when I'm going to flash the cannulas. So I can check those boxes off, draw a line through them, make notes on here. If I don't have time to chart during the process, I can refer back to that. And other people sometimes look at it as well. So we'll pay close attention to that and be prepared to flash at a lower flow and sort of creep up on our flow during the flash to ensure a good clearance of that old stagnant blood that was sitting in the cannulas. So once we have all of our ducks in a row, we've had all these discussions, we want to make sure everybody's ready. Is anybody not ready? We have all the players there. And then we will go ahead and start by clamping and declaring we're off ECMO at 11 o'clock. And the first blood gas then is due at 11:09, for example. And then we would flash at 11:10. So then once that happens, we will, throughout the trial and throughout the clamping, discuss how the patient is tolerating it. As the ECMO specialist, I like to be aware of what's happening on the other side of the bed. I do have to pay attention to my own job, but I want to know, have they escalated the epi, the vaso quite a bit? Have they had to paralyze? Are they on really high vent settings? How much volume administration are they giving? Are they giving any blood products? I do like to be aware of all those things so that I can advocate for my patient and say, maybe this isn't a good idea to keep going. Maybe we should give them a break. So we'll just have some bedside discussions with the healthcare team and decide how long we should go. And then hopefully echo is also at your bedside waiting to see how the patient's heart looks, maybe at the middle point and the end point of your trial. And if all goes well, hopefully that echo looks good and the patient can make a plan for decannulation. If the echo doesn't look that great, we might decide to go back on ECMO for another day or two, let the patient's heart rest and see how that goes. And that's, I think, a trial off.
Awesome. Well, as a non-clinical person, I'm always just really amazed at what an ECMO specialist is able to do and to accomplish, and the things that you all have to remember, and the processes and procedures that you go through. It's really impressive. Thanks for sharing all that information. If you have a question that you would like to hear answered by an expert, make sure that you reach out to me, Neil, at ECMOadvantage.com. See you next time.
Bye.